Hey everybody, welcome back to the ECG channel. My name is Reed. Don't forget before we get started to download the PDF that's linked in the description of this document so that you can follow along. And while you're there, feel free to like and subscribe to the page so that you can follow along for more. So let's jump into this. So this is a Holter monitor, and what a Holter monitor is a wearable device that people wear for maybe a week or so that we can capture their rhythm and determine if there's an arrhythmia that is needed to be treated. And so this is what we get here. And so we have 3 different strips that are occurring, and each of these strips are at a different time. And so let's talk about them. And so the first strip, we'll talk about this first strip. We'll call this strip 1. And let's take a look at strip 1. And so we're not going to obviously have our perfect, ECG, approach here because this is just a rhythm strip. But we can notice that we've got what appears to be a narrow complex QRS. It seems to be regular. It's ticking away. Okay. We see that it's got a rate of, if I start here, 300, 150, 100, 75, 60, 50, way slower than 50. We're going to call this slow bradycardia. Okay, so we've got a bradycardia, narrow complex bradycardia. And so we think, what's our differential for a narrow complex bradycardia? We could have a sinus bradycardia, we could have a junctional bradycardia, we could have AV blocks, you could have any type of second degree or third degree AV block. And so let's figure out what's going on. What's the atria doing here? When we compare it to this regular slow bradycardia, what you'll notice is that we've got P waves, these nice spiky P waves. See, this one is in the middle of the ST segment. This one's right before the QRS. And so if you notice here, the P waves are just marching through. There's it right on top of the T wave. Just marching through, and they're marching through at a rate of, if we count from here, 300, 150, 100, 75, 60, just maybe a little more than 50, maybe 55 beats per minute. Faster, we'll call that faster than our QRS. So the atrial rate is greater than the ventricular rate. And the atrial rate is regular, the ventricular rate is regular, and I don't see any correlation of any of these P waves conducting to these QRSs, right? If it's a second degree block, we might see some group beating, and so we don't see any of that. And so this top strip in that setting is a third degree heart block. And the third degree heart block is a complete heart block, right? Where none of that atrial signal is conducting through the AV node. The AV node is completely blocked. That's very concerning, right? And this person not only has a complete heart block, but we got to determine what's the escape rhythm. And so we said it's a narrow complex QRS that's occurring pretty slow. So this is probably, I would guess, a junctional escape. Okay. So maybe a junctional escape beat. Okay, so that's our first rhythm. Let's take a look down here at number 2. We'll do number 2 in red. What we notice here is we've got a QRS complex that is regular once again. And it is also incredibly slow. We could see 300, 150, 100, 75, 60, 50, 40, maybe probably somewhere in the 30s beats per minute. So we've got another bradycardia. Okay. What's the cause of this bradycardia? Well, the escape, or these complexes look a little bit different. They might look a little bit wider than our previous strip here. And something else that we see is we've got atrial activity at this time is marching through a little bit of a faster rate. Right, we see this P wave is probably buried in that QRS, P. You can see the P waves on the T wave there. So we've got atrial activity here, and the rate seems to be 300, 150, 100. Atrial rate is 100 beats per minute, okay? And at the same time, just very similarly to our previous rhythm strip, we don't have any P waves that are conducting to QRSs. The atria is regularly beating at 100 beats per minute, and the ventricles are regularly beating at roughly 30 beats per minute. Maybe even a little bit less, a little bit more. I'm not going to calculate it exactly. So what does that tell me? That tells me that the atria and ventricles are not communicating. There's no pattern here. So once again, we have a third degree heart block. This time, the escape rhythm looks a little bit different. We can maybe even consider this could be a ventricular escape. Okay. Now a little bit later in time, we get another rhythm here. We'll call this strip number 3. What you notice here is we've got, the rate seems to be a little bit faster and then a little bit slower, right? So look, you see we've got a little bit faster here, then we get a bit of a pause, and then we get a little bit faster again. And what you'll notice is that our QRS complex has resumed its form. If you compare these QRSs to our first QRSs, they look the same. So this is likely coming from somewhere within the AV junction. And what you'll notice is that there is a P wave for every QRS. There is one P wave for every QRS. The PR interval is a little long, so we do have an increased PR interval. And you'll notice here that we've got this single dropped P. That P is blocked. And so we've got this PR interval that is staying the same, right? So this PR interval is the same as this PR interval, and then this one drops. So when not all of the P's conduct to the QRSs, we know that basic definition of that would be a second degree heart block, right? Where some of the P's conduct to QRSs, but not all of them. And we need to determine, is this a type 1 or a type 2? And because in this case, the PR interval stays the same, this is a type 2 or a Mobitz 2. And we know that type 2 heart blocks are not good, and that can progress to a third degree with a very slow escape rhythm, which is what we see in strips 1 and 2. And so this person is transiently going in between a second degree and a third degree heart block. And so luckily, this Holter monitor helped us determine that. So an important takeaway here is that second degree type 2 heart blocks are heart blocks that are below kind of the AV node proper. So AV node proper here. And so we get these heart blocks are in these fibers. And why are second degree type 2 blocks in these fibers, kind of infrahisian fibers, so bad? Well, that's where we get our junctional escape beats. And so if second degree type 2 blocks progress to becoming completely blocked, then we are unable to conduct an escape beat, right? So the atria is going to be firing off and depolarizing the atria. But if this is completely blocked, none of those P waves are going to get down to our QRSs, and so we don't have the ability now to provide the ventricles with a junctional escape beat because the junction is blocked by these type 2 blocks. So these people, the last resort for their ventricles to depolarize is a ventricular escape beat somewhere within the ventricular conduction system, and those are slow. We know those ones are slow at like 20 to 40 beats per minute. And we know that sometimes that could be too slow depending on the person and their oxygen requirements, or we'll say their perfusion requirements to perfuse their brain or their vital organs. And so that's why these people need to get pacemakers quite rapidly so that they do not develop these heart blocks with slow bradycardias, which luckily this patient had those and was able to kind of come out of this unscathed. We had a good outcome, so happy to see it. If you have any questions, throw them in the comments. Don't forget to like and subscribe to the channel. Thanks for watching, and we'll see you tomorrow. Have a great day.